Hello, my name is Rachel Wilson, and today I am presenting a case study on serum sickness-like reaction, overview of diagnosis and management, alongside my partners Teresa Lawrence and Dr. Kathleen Martin. Serum sickness-like reaction is a rare acute inflammatory condition that classically resembles serum sickness, a type 3 hypersensitivity reaction. However, it appears to be caused by a different mechanism with a pathophysiology that remains unclear. Commonly, serum sickness-like reaction affects children with a rash, arthralgias, lymphadenopathy, and fever. It is believed to be an inflammatory response to recent drug intake, occurring 5 to 10 days following administration of the drug. Currently, therapy treatment guidelines are unclear, with the main recommendation to withdraw the culprit agent. We present a case of a young male diagnosed with serum sickness-like reaction who had symptom resolution with the administration of steroids. A 16-month-old male presented to their pediatrician with a one-day-old fever and progressively spreading erythematous rash. The patient was promptly transferred to the emergency department. The patient had no significant medical history other than 2 months of sinusitis, including treatment with amoxicillin and a cephalosporin, and a recent course of prednisolone and augmentin. Most notably, the patient had a fever, joint swelling, and rash. Upon physical exam, the patient had bilateral joint swelling. The patient's skin contained non-blanching purpuric lesions of the umbilicus, posterior neck and thigh, and diffuse small erythematous macules of the back. Lab results included low white blood count and platelet counts and a high creatine and CRP. Starting at day 2 in the emergency department, the patient was initially treated with dexamethasone, Benadryl, saline, Tylenol, and Motrin. At this point, the patient was transferred to a larger hospital, and there was an improvement of the lesions, as well as improvement in his fever and joint swelling. By day 3, the rash worsened, and dermatology confirmed a diagnosis of serum sickness-like reaction. As the rash persisted, dermatology recommended the conversion of methylprednisolone to dexamethasone due to symptom improvement in the ED. The patient was discharged on an oral steroid taper, with all symptoms resolved by the day 7 follow-up, and with no ongoing complaints. These images depict the rash progression from the ED to the hospital admission. The first 2 images on the left show the patient upon initial presentation to the ED, where augmentin was stopped and dexamethasone and Benadryl were given. The third image from the left shows rash improvement after transfer and administration of the steroid. However, the last photo, the one on the right, was the second day of admission and shows the rash becoming more diffuse and erythematous. Dermatology was consulted during this time with the recommendation to administer dexamethasone instead of methylprednisolone, as they did in the ED. In summary, serum sickness is a type 3 hypersensitivity reaction that commonly presents with rash, fever, and joint pain. Serum sickness-like reaction classically resembles serum sickness. However, serum sickness-like reaction more commonly affects children. While the pathophysiology remains unclear, it is believed to be caused by an inflammatory response to recent drug intake, especially that of antibiotics. Vaccines and certain bacterial and viral infections, including streptococcus and hepatitis B, have also been associated with serum sickness-like reaction. It is important to consider serum sickness-like reaction when patients present with a fever, cutaneous findings, and joint pain. It is important to note here that the cutaneous findings may vary in patients. While there are several differentials, 3 to keep in mind are Stevens-Johnson syndrome, Kawasaki disease, and urticaria multiforme. Stevens-Johnson syndrome was the initial differential on this case. However, the patient lacked skin sloughing and mucous membrane lesion involvement. The diagnosis for serum sickness-like reaction is made clinically. Lab findings may include neutropenia, thrombocytopenia, and an elevated ESR-CRP. These findings were consistent with our patient. Several cases have reported decreased complement proteins such as C3, C4, and CH50. However, this was not the case with our patient, further showing that not every patient fits that perfect presentation. Current management involves removal of the causative agent. NSAIDs may be used for joint pain and swelling, as well as antihistamines for those who present with a pruritic rash. Currently, the use of steroids for more severe cases is based upon a small number of studies and a limited number of case reports in the literature. This is why this case is important for us to report. In conclusion, serum sickness-like reaction should be considered in a young patient presenting with fever, rash, and joint pain and stiffness following recent drug or vaccine exposure. IV steroid usage followed by discharge with oral tapering proved to be a means of management. This case is of importance as it joins a limited number of reported cases in which steroids proved to be a means by which symptom resolution occurred. And currently, there is a lack of evidence-based guidelines for the effective treatment of serum sickness-like reaction, as well as a question of long-term effectiveness and safety. We hope that reporting cases such as this one will aid in improving management and positive outcomes for those diagnosed with serum sickness-like reaction. Thank you.